Okay, now we're going to get into the dead rhythms. And so this brings back our basic life support. So what I want you to do is, if you're at home, in class, or wherever you're at, I want you to get a pillow out or a chair or whatever, or um, something where you can practice the steps of basic life support. This kind of goes over the steps. It's in CABB, excuse me. Check responsiveness, colico glue, check circulation, do chest compressions. Open the airway, give 2 breaths, 5 cycles of 30 to 2, chest compressions and breaths. You don't really have to worry about what am I doing, what am I doing. You just go back to cycles of chest compressions and breathing for the patient. And then the last step is D, check for a shockable rhythm, defibrillate. And then the next slide will be given a video, and I'll perform the steps. You can kind of see that. What I'd like you to do as the video's going is you perform the steps of basic life support as a refresher for you.
Joel, are you okay? Are you okay, Joel? This is not right when we call. I'm so breathe here. It's a false part. Don't go pulse. Spend 10 seconds. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10, 12, 13, 14, 15, 16, 17, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One, 2, 3, 4, 5, 6, 10, 11, 12, 13, 14, 15, 16, 17, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 9, 10, 11, 12, 17, 18, 19, 20, 21, 22, 26, 27, 28, 29, 30. 1, 2, 3, 4, 6, 7, 8, 9, 10, 13, 14, 15, 16, 17, 18, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 5, 6, 7, 8, 9, 10, 13, 14, 15, 16, 17, 18, 19, 20, 24, 25, 26, 27, 28, 29, 30. You get that. Anybody help me? The patient's coming in here. Turn on.
Apply pads to patient's bare chest.
That's electrode.
Plug in pads connector next to flashing light. Apply pads. Plug in connector. Analyzing heart
Source of
rhythm.
oxygen.
Do not touch the patient.
Bring back.
Shock advised. Charging. Stay clear of patient. Deliver shock now.
I'm clear, you're clear, we're all clear.
Shock
Shocking.
delivered. Paused. Begin CPR.
1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Hey, Joel, are you okay? Are you with me? Good, like you got your eyes open here a little bit. Are you breathing? Okay, looks like your chest rising, yeah. Looks like we're doing okay. Good. Let's get the cardiologist online and see what happened. You're welcome.
Okay, so after we get down to CAB, and then D would actually start here. So D is the end of the last survey, the primary survey in basic life support, and then we will begin the steps of ACLS, is CABD, and the secondary survey. So here, this is the algorithm that shows, so we're doing CPR, get the patient on a oxygen monitored defibrillator, check for a shockable rhythm. We've done that. If it shows VFib or VTAC, we'll shock. If it shows asystole or any other rhythm at all, PEA or pulseless electrical activity, then we'll go down those ways. So we'll look at these on here. You can look at the algorithm here for a little bit. Okay, so we look at the left side and we see ventricular fibrillation or pulseless ventricular tachycardia. That's what the two rhythms look like. In basic life support, you may not see those rhythms. In ACLS, when we use a crash cart, we'll be able to see those and make those determinations. You can see with the ventricular fibrillation, there's no organized rhythm. The ventricles are just quivering. And then pulseless ventricular tachycardia, it's going so fast that they can't feel. But both of these are non-perfusing rhythms, so we check a pulse. There is no pulse with these patients. So we want to see that. We want to check on these patients, see how they're doing. We want to defibrillate these. What defibrillation does is obliterates the electrical stimulus so that the normal SA node can take over. A lot of times you see in movies and stuff, they're saying, well, let's jump start the heart. Well, we're not jump starting the heart, we're stunning the heart. So we need a lot of electricity to do that. And so when we talk about defibrillating at 360 joules or less with a biphasic one, we will talk about overwhelming the heart or stunning the heart and obliterating the electrical stimulus. So we need a lot of electricity to overwhelm the heart. Can we use pediatric ones on pediatric patches on the adult? No, that's correct. But can we use adult patches on a child or infant? Yes, we can. That's right. So we need too much, but not enough electricity can desensitize the heart and make it to where it's not responsive to the shock. So VFib, pulseless VTAC, defibrillate only these two rhythms, and it obliterates the electrical stimulus, and that's what we're going to do in this situation. That's the last step of the basic life support. Okay, so we can see basic life support, primary survey, CABD, defibrillate, VFib or pulseless VTAC, and now we're going to start the secondary survey. And it begins with C, the CABD, and the secondary survey is a little bit different. So we resume with chest compressions, we resume the circulation, and no delays more than 10 seconds. We establish circulation by establishing an IV or IO and give medications based on the rhythm. So in this case, VFib or VTAC, we give epinephrine. We choose a vasoconstrictor, epinephrine or vasopressin. We choose an antiarrhythmic, amiodarone, if amiodarone is not available, and any electrolytes like magnesium if we know that the magnesium's low. And so you have some of these steps here, but this all begins with C, resume, you check for circulation again, resume circulation by doing chest compressions, a 30 to 2, 30 to 2, with no more delay, establish an IV, give medications based on the rhythm. Okay, and we continue, but the airway this time is not just opening the airway. We've done that already. Now we're going to place an advanced airway. So generally the patient would be intubated with an ET tube, endotracheal tube, or some type of advanced airway to secure the airway so we can breathe for the patient. Once the advanced airway is placed, you no longer have to synchronize your chest compressions. You can just give your chest compressions without having to wait and do the 30 to 2. You get one breath every 5 to 6 seconds without an advanced airway, and then one breath every 6 to 8 seconds with an advanced airway. And we breathe for the patient, and then we go to the differential diagnosis. That's the CABD. So the D on the primary survey was to defibrillate. The D on this one is to try and figure out what's going on. Determine the cause or differential diagnosis. We have 5 H's and 5 T's. So how do we treat hypovolemia? Well, we give fluid. How do we treat hypoxia? Well, we give oxygen, make sure our airway is patent. Hydrogen ion acidosis, that's an acid, then we're going to give a base, we give bicarbonate. And you see on the crash cart, you'll see the yellow Bristol jets that you flip off the tops and connect them, and you can give that. Hypokalemia, we're going to give potassium. Generally, you do not push IV potassium. You kill the patient. You can that's how you stop the heart. So you have to hang IV potassium and run it over an hour. The most you can give in an hour is 20 milliequivalents, as long as you're on a heart monitor. Typically, in hospitals, you see 10 milliequivalents given over an hour, but the most you can give is 20 milliequivalents. That's to be monitored. Hyperkalemia, how you treat that? Well, there's 3 things. Insulin will force the potassium back into the cell, but you'll drop out the blood sugar, so you have to give D50. So insulin plus D50, calcium chloride, and sodium bicarbonate will all force the potassium back into the cell. That's an emergent situation. Hypothermia, you can rewarm the patient. Now, if a patient's unresponsive and coming back around their vital signs, they may be a candidate after a heart attack. They may be a candidate for therapeutic hypothermia. So you might consult with the physician or expert consultation to see if the patient needs to be rewarmed. But many of the medications will not work until the patient's warm. Used to be we would say you can't pronounce the patient dead until they're warm and dead. And so we would have to get their body temperature up to see if the medications work and before they could be pronounced or the code called. So it's a little bit different now when we have options for therapeutic hypothermia. So you need expert consultation to address that. The 5 T's, we have 2 hearts, 2 lungs, and another one here. So what are the 2 hearts? Cardiac tamponade, where there's fluid that surrounds the heart. Classic signs is jugular venous distension and muffled heart sounds. So cardiac tamponade is a needle decompression to draw out the blood. And the other heart is heart attack, having a heart attack. It's a blockage, not giving oxygen and the muscle dies. So the goal is reperfusion. The 2 lungs is pulmonary thrombosis. So much like the heart attack, there's a blockage or a clot there and needs to be unclotted. So instead of the heart, though, we're talking about the vessels that's going to the lungs to where they're going to have an exchange, and one of those is blocked. So many times an advanced catheter like a Swan-Ganz catheter we place, a pulmonary artery catheter, and thrombolytic medication placed in there to see if they break up the existing clot. Tension pneumothorax would be where you have the lung that's been traumatized, and so our lung system is the closed system when you breathe. So if you open that up, then automatically the lungs would deflate. So what this is air going in, and then the flap closes and it can't get out. Air goes in, can't get out. Air goes in. So you can see that would compress the heart, push everything over. So tracheal deviation is, and no lung sounds are classic signs with that. And you do needle decompression with a needle, 18 gauge needle. Actually, I had to take care of a patient one time, and I was in with the patient, and he wasn't doing well, and his sats kept dropping. We kept giving him more and more oxygen. He was on the ventilator, wasn't doing well. I called the resident, and I said, something's going on. It's a traumatic injury to the patient, and he said, it sounds like a tension pneumothorax. You're going to have to do a needle decompression because you're losing the sats too quickly. By the time I get up there, he may be gone. So you have to do that. And I was like, okay, I've read about that, but I haven't done that. He's like, you've got to do this. I'll walk you through this. And so I got my charge nurse and said, hey, we got to go do this. And we went in there and we found mid-clavicular line, second intercostal space, and we stuck the needle in there, and you could hear the air release, and it relieved the tension pneumothorax. And then the physician got up there. Immediately, SATs went up. Physicians got up there and said, hey, man, good job. Now let's place a chest tube in the patient. So we do that. But we kept watching. The patient kept not doing well. We couldn't keep the sats up, and like, what's going on? He placed the chest tube, and I was like, did we ever take the needle out of that guy's chest? He's that's probably it. They're just letting air escape. He's the right. So we went and took the needle back out that we placed in there to help save his life, and now then he did better and did fine. So that's my kind of tension pneumothorax story. Toxins, again, it really depends on what the overdose is, because you just can't treat everything the same. But for sometimes you can alkalize the urine, and for some medications that would be effective. So sodium bicarbonate may be, but like if it's a digoxin overdose, you give Digibind. So you really have to know what the drug is or have some type of history on the patient to treat that adequately. And then the other side of the algorithm is we check for it. We go down to, on the primary survey, the last step is what? D for defibrillation. We check for a shockable rhythm. And we have PEA can be any rhythm except B-fib or pulseless VTAC, any rhythm at all and without a pulse, and that's PEA. So it can look pretty on the monitor. Oh, that looks like a normal sinus rhythm. That looks fine. But the patient doesn't have a pulse. So we may be able to talk to the patient or see if the patient's alive before we just trust that that's what that is. So PEA is showing here, or asystole, where there's a straight line. Again, check the equipment. Maybe a patient got up to shave and pulled off a lead or something. Now we send the whole team and crash cart in there, and everybody starts doing stuff, and he's in there shaving or something. So confirm in another lead, confirm that patient's on the monitor appropriately, confirm that there's no malfunction with any of your equipment, that the asystole is true and correct. So we're going to go this way, and we do the CABD as a secondary survey. We resume CPR with chest compressions, 5 cycles of that, establish IVIO, utilize advanced airway, breathe for the patient, and then drugs that we're going to consider are epinephrine or vasopressin only. And that's what we're going to do. And then we're going to look at our 5H's and 5T's and see if there's something we can correct with that. Otherwise, our 5 cycles of chest compressions and ventilations, epinephrine or vasopressin, we're going to give, and then we'll see if we can determine reversible causes and see if we can fix it that way. Otherwise, if the patient's in asystole, been like that, then it's probably we're going to try all of our medications. We can try and figure out things, and then the patient's probably going to be pronounced then. So that's those. Okay, and then some NCLEX style questions I want you to kind of look at and say, read this. And before you look at the answers, I want you to read the question, reread the question, and really see what they're trying to answer first. In both of the questions, many times students want to go immediately to the answer. You commit to an answer that's familiar. You have an emotional connection with that answer. You want to marry that answer, and then so when you read, you're going to force the question to fit your answer, and that's not what we're trying to do. We're trying to force the answer to fit the question. We're going to say, does this answer this question? If it doesn't, then I can't pick this answer. And so I want you to look at it from that perspective here. And then using the decision tree to kind of answer the questions, think about assessment versus intervention. I always do assessment versus intervention, but assessment can even be an intervention. The thing we need to think about is, do we have enough assessment information in the question to answer and move to an intervention? Or do we need more assessment information? So in the first one, the patient comes in with a rhythm that is interpreted as atrial fibrillation, heart rate 162, blood pressure 80/42, respiratory rate 24, O2 sats 98%. What's the RN's first priority? Now again, we have to go back and say, what is this asking for? So atrial fibrillation, we know that's a narrow, complex tachycardia. What do we want to do? Patient has a pulse, and because it says they're talking, the heart rate is fast, blood pressure is low. So I'm asking myself, is the patient stable or unstable? Blood pressure being low. Okay. Do I need any more assessment information? Do I need more assessment information? If I do, I can do that. But if I know I've answered my question that it's unstable, what do I actually go to? That's right, D, I set it for synchronized cardioversion. Go to, the patient has a rhythm showing bradycardia, 52 heart rate, sats 94%, respiratory rate 18. What's the first priority? Now, do I have all my information? The heart rate's 52, which is low. O2 sats 94%, which is possible. Respiratory rate normal. It's on the high side, but it's normal. I want to intervene, but the thing is that I don't have enough assessment information to answer the question, is the patient stable or unstable? I need a what? I need to say, is it having an acute altered mental status, signs of heart failure, signs of shock, hypotensive? Do I know those answers? So let's see if any of the answers give me more assessment information. Assess the patient's blood pressure. Okay, so that would answer to see whether the patient's stable or not. So I need to know that before I say how I treat the patient. So those would be the two answers, D and C. And here again, I'm going to just give you a few minutes to try and reflect on what's been taught. I would like you to be able to teach this to somebody else and make sure you have this. So I'm going to give you a few minutes to write this out on a piece of paper and teach it back to me, or teach it to somebody that you know. Good. Keep going. I'll give you about a minute more. All right, guys, we'll just go ahead and wrap this up. You guys have done a great job. Thank you.